All right, great. Welcome everyone to the ASNR Neuroradiology Webinar Series, Industry Innovates. And today, this webinar is brought to us by our friends at icometrix, longstanding supporters of ASNR and committed to education of radiologists and care teams and advocacy for our patients, getting them the best possible care. So now while we're waiting for everyone to come in, I get to do my housekeeping slides. My one housekeeping slide. So when you have questions during the webinar, please enter them in the QA panel. The chat box is for us to say where we're from, kind of introduce yourself if you want to have casual conversations amongst yourselves. But real questions that will be addressed to the speakers at the very end of the webinar. We have several speakers, so hold them till the end. Put those in Q&A. And you can hide your chat box. If you don't want to see it, connect with ASNR on social media. We should ask Colleen at another time if they have Blue Sky. I don't know if that's one of those too, but connect with us there for more information, cases, all kinds of stuff from ASNR. And connect with icometrix on social media as well. That's great. All right, so now I'm going to introduce the host of this session, Dr. Smeets. Dirk Smeets is the Chief Technology Officer at icometrix, PhD in biomedical engineering and artificial intelligence. But you all know Dr. Smeets already because he's done a number of our webinars. Great educator. And like everyone in this expert panel that's going to be speaking to us today, kind of this is a special group because they all do more than one thing. They have their background, their areas of expertise, but they also know very much about all of the expertise of the teams they work with as well. They're breaking down silos and helping us all learn together to provide the best possible patient care. Dr. Smeets is going to introduce the other speakers as well as his vision for this webinar and how we're going to learn about the expanding role of radiology and AI in the diagnosis and monitoring of multiple sclerosis. Dr. Smeets.
Wow, this is so exciting. Thank you so much for that super kind introduction, Dr. Gibbs. And I'm super excited today for sharing with you an important change on the role of radiology and also AI in the diagnosis and monitoring of multiple sclerosis. But let's take a step back first and look how multiple sclerosis has been looked at for many years, where the clinical phenotyping was done in typically 3 categories. At first, there is the most common form, most patients have this form of MS. It's called relapsing remitting multiple sclerosis. That's a type of MS that is characterized by periods of relapses where symptoms appear and worsen, and then followed by periods of remission where the symptoms are improved or disappeared. Typically, some worsening accumulates over time. The second phenotype typically is the primary progressive multiple sclerosis phenotype, where there is that gradual decrease of worsening, and that without periods of remission. And that is different from the relapsing remitting form. There is also the so-called secondary progressive MS type, where that typically starts with the relapsing remitting onset that then transitioned in a more progressive form of MS. So as mentioned, this has been the view for MS for many years. And currently, to treat those patients with MS, there are many options in suppressing the relapses. And I must say that from the over 20 disease-modifying treatments that are available, there are many really good options that really are able to reduce the relapse rate and therefore also improve the outcome of patients over time. And from the radiology perspective, there is an important role already in this classical view, counting lesions, especially the contrast-enhancing lesions, which are a sign of a subclinical relapse, and new and enlarging T2 flare lesions, and sometimes also have the possibility to comment on brain atrophy. However, that view is now seen a little different, actually. And I want to share that by hand of this story of this 40-year-old woman with an 8-year history of relapsing remitting MS. She has been treated with different platform therapies, and from the clinical and radiological perspective, she had some breakthroughs, and therefore the patient was moved into a high efficacy treatment. This is very typical pattern of progress of disease for multiple sclerosis. And on that high efficacy treatment, the patient stayed free of relapses, and there was also no new MRI activity in terms of new and enlarging T2 lesions or GAT-enhancing lesions. But that patient felt actually worse, particularly after some time. Capabilities of walking are impaired. She noticed a reduced tolerance for exercise, for example, when running 2 kilometers, and that also worsens over time. Also, from the cognitive perspective, she felt that she was slower, and she reported the so-called brain fog, which also gave her difficulties at work. And that is actually a kind of a paradox, because from the radiological perspective, the patient seems stable, there's no progression, and also from the neurologist that looked at the radiological report says there is no reason to worry for potential progression. But that actually shows that there is going on more than we thought in that classical subtyping of multiple sclerosis. And nowadays we look at it more as a new way of disease. More particularly, we look at multiple sclerosis as the superimposition of 2 kind of almost independent diseases. On the one hand, there is the active inflammatory component of the disease, and on the other hand, there is a new type of disease that is called the smoldering disease or the smoldering associated worsening. And if we look at it from the pathological perspective, this relapse-associated worsening is caused by focal inflammatory activity, and it is also characterized by clinical relapses, acute and subacute neurological symptoms, and also it goes with visual loss, motor deficits, and sensory deficits. On the other hand, that smoldering-associated worsening is also kind of explaining some of the symptoms that I described in the use case in my slide before. There is that gradual accumulation of disability, there is motor symptoms and cognitive decline, fatigue, and general deterioration. So we now look at MS as the combination of these 2 disease processes. And that, of course, has also a major impact on how we need to look at the care of people with MS. So if we try to improve care, we want to reduce the worsening of that patient. And to do that in the best possible way, we need to try to disentangle the worsening that is associated with the relapses from the worsening that is associated from the smoldering disease. And this is nicely visualized in this graph. You can see that at biological onset of the disease, already that smoldering associated worsening is supposed to start, and it gradually increases over life. Whereas a relapse-associated worsening has a certain period when it starts, and it also decreases in the later phases of the disease. Of course, not all of that worsening is clinically detectable. If you look at the clinical way of detecting disease, often it can only detect it when the relapse-associated worsening becomes too high over that detection threshold, and that is typically what we call the clinical onset of disease. But as you can see, the disease is actually starting earlier. And what if we could detect earlier? What if we could detect the disease already at biological onset? And that is, of course, an important aim that we're now looking into. Can we use imaging to find earlier markers that allow to make the diagnosis earlier and as possible already at the biological onset of the disease? So that is our number 1 aim now, is to see how we can improve the diagnosis. And that requires also an increased diagnostic specificity, because these relapses and the symptoms of the relapses are also something that occurs in similar diseases than multiple sclerosis. So we're looking also for markers that are more specific for MS. On the other hand, there is also an impact on the monitoring, because we know now that there's two types of disease processing coming together, the relapse-associated worsening together with the smoldering-associated worsening. And I think it's important to try to disentangle them. Why is it so important? Because probably different treatments have a different treatment effect on each of these components of the disease. And maybe in some future, we will have very effective treatments for each of those components. And by disentangling them and already monitoring them, we will be able to treat our patients in the best possible way. So that actually ends my introduction. And with that, I also would like to start the introduction of our incredibly luminary panel today. First of all, I would like to introduce Dr. Pascal Setti to you. Dr. Pascal Setti, he's a distinguished director of the neuroimaging program at Cedars-Sinai, and he's quite known for his groundbreaking work in the field of chronic active lesions, the multiple sclerosis. And he brings a wealth of experience and a unique perspective on this topic. And today he will be talking about the enhanced role of radiology in diagnosis MS, and especially the new 2024 McDonald criteria, which of course is a real good reason to pay a lot of attention to. After Pascal's talk, I'm super excited to have Dr. Amit Mahajan also joining our webinar today. He's the program director of at Neuroradiology and chief of NeuroMR at Yale, and he will be speaking about how to implement the new diagnostic and monitoring markers in clinical practice and to see also how AI can help. And finally, I will also say some words on how these AI tools can help in the evolving landscape of multiple sclerosis. But without further ado, I would really like to give the word now to Dr. Setti.
Thank you, Dirk, for the kind introduction and a beautiful intro to this webinar. Let me just make sure I can share my slides with everybody. Well, so as Dirk just introduced, we have an exciting moment happening right now in the field of MS, and specifically that shift in our understanding of the biological processes that drive the disease progression that clinicians are seeing in the clinic and patients. So this is actually now fueling a new wave of tools, and specifically imaging tools that can help us better diagnose and monitor patients. And I'm hoping over the next 20 minutes or so of my talk to show you some of these very exciting tools are actually going to hit the clinic very soon, specifically with the new McDonald criteria that are coming up. So I'm going to walk you through three main topics today in this talk. We're going to start discussing a little bit of the role of imaging in MS, just go over the basics, and then show what is happening now with the new McDonald and how we're going to expand the role of MRI. And I'm going to dive a little bit into the 2024 McDonald criteria, but with a look through the prism of radiology. So I'm going to emphasize primarily the MRI changes to the McDonald criteria. And then I'm going to wrap it up with some discussion about the expanding role of MRI for monitoring MS and how we can use some of the novel biomarkers that we use diagnostically for monitoring MS and even potentially assessing treatment effect of a new class of therapies that target chronic inflammation or smoldering inflammation, as Dirk just mentioned. So let's start with the expanding role of MRI for diagnosing MS. So I think I don't need to remind this audience that MRI is a time-tested method for detecting MS lesions in the brain and spinal cord of patients. And it's an integral part of the diagnostic criteria since its introduction 20 years ago. And the key features that MRI can determine non-invasively is both dissemination in time with demonstration of new lesion, dissemination of lesions in the brain and spinal cord, but also dissemination in space with the presence of new lesions or gut-enhancing lesions. And that really has really improved the sensitivity and the time to diagnosis since it's been introduced into the McDonald criteria. Now, just a quick reminder for everybody out there who is reading cases, MS cases, as per the 2017 McDonald criteria, which are still the one that are to be used because the 2024 haven't been published yet, and I'll give you more info on that. But as of now, DIS and DIT remains the pillar of demonstration of MS in patients that have typical attack. And again, demonstration of lesions in the periventricular areas, cortical juxtacortical areas, infratemporal and spinal cord are required for dissemination in time, with at least one lesion in at least 2 locations. For DIT, as a reminder, we are looking for enhancing and non-enhancing lesion on post-GAT T1 weighted scans, or new T2 lesions on a follow-up MRI if it's not present on the first assessment. Now, this approach that has been used until now has shown to have some limitations, and there is an accumulation of evidence from studies in real-world clinic showing that even though we have improved the sensitivity and shortened the time to diagnosis, we are still facing issues of diagnostic delays, where, for example, we cannot demonstrate DIT at the first MRI scan because there is no enhancing lesions, or we are dealing with complicated cases where you can have comorbidities on board or confounders of non-specific white matter lesions that make the diagnostic workup more complicated. And that points to the lack of specificity of MRI. We are very good at detecting pathology in the brain, but we are still not very good at differentiating what is truly MS pathology from other mimics that typically can have radiological findings. And that has resulted in a pretty alarming rate of misdiagnosis in the community. And we have studies even published from Cedars-Sinai here, where we look at the Los Angeles community and found almost 20% of people coming to us with a MS diagnosis not having MS. And you can see the harm to that because, people that have the label of MS can be treated with pretty potent DMTs. And if they don't need that treatment, they can be exposed to unnecessary risks that can be sometimes life-threatening. So there is really a challenge in having a more accurate diagnosis of MS. The other thing is about 50% of the patients that present to clinic for referral of MS don't typically have this attack that is characteristic of MS. They can have atypical symptoms that are not really suggestive of an inflammatory demyelinating process, but can still be MS undercover. And as of now, the 2017 criteria cannot be applied to this population. So we might be missing out on a lot of patients out there that do have MS but are being non-diagnosed yet. So in the light of these challenges, the 2024 revisions of the McDonald criteria were announced last year at ECTRIMS in Copenhagen by the chair, Javier Montalban, who is the chair of the past chair of the International Advisory Committee on Clinical Trials in MS, with the goal to basically address those challenges. And so this revision has been announced, but haven't been published yet. We, as of now, have papers submitted to Lancet Neurology under review, and hopefully this will be published throughout the summer. So please be patient with that. And what I'm going to show you right now is what has been submitted and might not be the final version of the diagnostic criteria. But what I can tell you already is that the role of MRI has been significantly expanded with the addition, as you can see here in orange, of new features. First, for dissemination in space with a 5th topography, with the optic nerve as the 5th one. And then a major change that really differentiate from the previous revisions, which have been always relying on T1 and T2 lesions, now is the addition of new biomarker, and specifically the central vein sign, or CVS, and the paramagnetic rim lesions, or PEARL, which are aimed at bringing the specificity, the pathological specificity that we need to differentiate MS lesion from non-specific white matter lesions and other mimics. So let's then pivot to this McDonald criteria. What are the changes that should matter to you, radiologists out there, that are going to have to read those cases and adjust to these new changes? Well, they are pretty significant, and there are actually 5 of them. And the good news is I'm going to try to walk you through them today and help you bring some understanding so we can reduce the complexity of these changes. The first one is, as I pointed out, the addition of a new topography, the optic nerve. So again, in addition to the juxtacortical and cortical, periventricular, infratemporal, and spinal cord, now we're going to be looking for T2 lesions or T1 enhancing lesion in the ON. And why are we doing that? Well, it's known clinically that this is a very common and important manifestation of MS. And about close to 20 to 30% of CIS patients will have an optic neuritis. And now there is sufficient evidence, and that's why this panel of experts have integrated into the McDonald criteria the use of optic nerve lesion as a topography for DIS. So in terms of practical implementation, what is going to be recommended very soon is to add an MRI sequence to detect the optic nerve, ideally image at 1.5T or more, with 2D or 3D imaging, pretty thin slices and pretty high resolution in play, but acts with coronal views, and typically a fat suppressed T2 weighted austere, as I'm showing on the top, or a post-GAD or a post-GAD coronal fat suppressed T1, I'm showing the bottom. Additional sequences can be added if time allows, such as the 3D DIR and axial sequences as well. But this is going to be now required to image and detect this fifth location, the fifth topography. Second change, the central vein sign, or CVS, now may be used in the diagnosis of MS. So this is a novel imaging finding, but it's actually a pretty old histopathological finding. It's been known for over a century now that MS lesions typically form around a vein. And this inflammatory perivenular demyelination is really a classical presentation of MS lesion. When you look under the microscope and look at autopsy tissue, classic LFB stain will always reveal an area of demyelinated area with a central vein. And mechanistically, this perivenular formation of demyelination has been already well explained and theorized for many years ago. So this is not a novel feature in per se, but what is novel is the ability to image that non-invasively using MRI. And susceptibility imaging has been key here to image that, because veins do have a paramagnetic nature given the deoxyhemoglobin, which is highly paramagnetic and allows it to detect as a thin hypointense vein on susceptibility MRI. Now the key finding here for radiologists is to make sure that that vein, which is typically a deep medullary vein, has to run centrally through a T2 hyperintense lesion. It could be thin as a line here on the axial view, or as a dot if you look at the perpendicular plane, always centrally located within the T2 lesions. And many studies have shown until now that this is actually a very, very specific biomarker for MS. So the good news is there are already FDA cleared sequences to do this clinically. I'm listing a few of them here. So the SWI, the T2 star weighted scans, Flare star, which is a more novel sequence, and Swan Vignal, which is another optimized sequence, are clinically available, and they will depend on the vendor. And I believe Dr. Mahajan will show some example of his own practice at Yale. So I'm not going to go too deep into this, but just want to mention that these sequences exist and can be implemented nowadays in your protocols. Now I'm pivoting to the third point, which is the other biomarker, the paramagnetic rim lesion, or PEARL, which also may be used now in the diagnosis of MS. And so this is, again, something that is a biomarker has been very well established histopathologically. These rims of iron actually are seen in chronic active MS plaque, and this reflects basically the presence of activated microglia, macrophages that are pro-inflammatory, and then store iron that has been released by demyelination through ferritin, and ferritin is highly paramagnetic. And again, that constitutes therefore a contrast for us for susceptibility imaging. What is really interesting is that this is also a marker of this smoldering inflammation that Dirk just mentioned earlier, what I like to call compartmentalized chronic inflammation, which has been shown to prevent lesion repair and drive slow lesion expansion over time, and is really a good marker for disease progression. So how does it look like radiologically? So similarly to the central vein sign, you want to use a susceptibility MRI sequence. And here what you're looking for is a thin hypointense rim, as I'm showing here. And this is an example of a pearl, a beautiful example of a lesion that should be a true textbook pearl case that you want to look for in your cases, where it has to colocalize with the T2 lesion. And this colocalization is key. And I want to emphasize that it has to correspond to a continuous line that has to surround the lesion for at least 2/3 of this outer edge. And that lesion has to be non-enhancing because by nature, it's a chronic active lesion. We recommend that these lesions are typically seen on at least 2 consecutive axial slides for increased confidence. And when you do this, you can be assured that you have a very high diagnostic specificity because, again, studies that have been published over the past 10 years have shown a very high performance using Pearl as a standalone biomarker of about 90 to 100% specificity. So going back to the implementation, how do we image those? Well, good news, susceptibility imaging can be used again. And this time I'm showing example of pearls on different sequences, and you recognize some of the names I mentioned before, SWI, T2 star weighted, and this one, filter face, and they're FDA cleared and available. And again, this availability will depend on the vendor. So I'll ask you to check your vendors, individual vendors, to make sure that you have access to one of these or all of them. And here's an additional table, and I'll pause a little bit here for people to take snapshots, although I know this is being recorded, but this is going to be the recommended protocol that's going to be published very soon, one of the companion paper to the McDonald criteria, which will be the new CMSC names guidelines for imaging those two biomarkers. And the good news is you can do with different sequences, and I already mentioned the SWI. The thing I would like to emphasize here is we recommend optimize SWI by changing a little bit the flip angle. And I think Dr. Mahajan will show an example of that, again, from his experience at Yale. But the idea is you can optimize the sequence to detect both CVS on magnitude SWI and Pearl on filter phase SWI. And here's the recommendation that we recommend in terms of parameters with, of course, high resolution, because these are thin details, very thin markers that we want to detect, whether it's a line, a central vein, or a rim. So high resolution imaging is required. You have also the option to use a little more advanced sequences, such as a 3D EPI sequence with a strong T2 star weighting and the phase filtering turned on, and that will allow you to do these isotropic scans that can enable MPR or multiplanar reconstruction. 1.5T is feasible, but we do recommend also to optimize this protocol by pushing the T or using the GATO when available during the diagnostic protocol. So now moving on to the fourth item, which is a lot, as you can tell, and really basically build up on the DIS and DIT by adding new combination of the imaging biomarker to establish a diagnosis of MS in people that have typical presentations. So here's the actual algorithm. It's a little complicated. We're not going to go through this. This is actually very much for the neurologists to look at. But for radiologists, what I want you guys to understand is in people that have typical presentation, and will come to you on the MRI, what we really need to get from you in the report is the report of DIS. So we're looking for, again, the topographies, dissemination in time, DIT, and then CVS, because by combining those, we can actually establish an MS diagnosis. And here's the three typical combinations that are going to be possible. So if you find T2 lesions in 4 to 5 of the topographies, including the optic nerve, this is already MS. DIT is no more required. DIS plus DIT with typical 2 to 3 topographies is still valid and still useful, and that still will be mid-MS. And the other innovation is now you can combine DIS and typically 2 to 3 topographies with CVS. So if you find the central vein sign and you have DIS, you can already establish MS. Another innovation is really a new advance is now you don't even need to require sometimes DIS. So if you have only one topography, but can demonstrate CVS plus DIT, you have MS. If you have one topography plus Pearl and DIT, it's also MS. So as you can see, there are many more combinations that are not possible to establish MS in a typical presentation. And the idea is, again, to speed up the time to diagnosis while increasing the specificity by looking at very specific biomarker of MS, such as CVS and Pearl. Now, pivoting to the fifth and last major changes of this McDonald criteria is the ability to diagnose MS in people that have radiologically isolated syndrome or RIS in specific situations, which basically means that a radiologist, by just looking at MRI, could actually diagnose MS. And this is building on years and years of evidence that have been showing that the majority of RIS subjects will have MS over a 10 years period or 15 years period. So RIS in most cases is actually pre-MS, preclinical MS. And so now we have the ability to detect this by MRI sensitively, but also with high specificity. And so this is what this new criteria will imply now, that in people that have RIS, and I want to remind this audience that RIS means incidental discovery of CNS white matter lesions on T2 scans, which are typical for MS, and the absence of typical symptoms. In that case, you can start now applying DIS and DIT. And if they meet this, then they can be diagnosed with MS. The other combination that is allowed is DIS plus CVS, which also would be sufficient for diagnosing MS. So again, these are 5 major changes that I think radiologists need to be aware of and need to start thinking about reporting in their diagnostic report. I'm going to wrap up my talk with the third part, so a little discussion of the expanding role of MRI for monitoring MS. So as a reminder again for this audience, follow-up MRIs are strongly recommended for people that are treated or not with DMTs. The current recommendation for, based on the 2021 Magnim CMSC names, call for annual brain and cervical spine MRIs in MS patients. And the assessment of new or emerging T2 lesions is required and should be reported, as well as the presence of GAD-enhancing lesion when GAD is used. And the idea is, again, to monitor that active inflammatory component of the disease that Dirk nicely introduced before. And then brain volumetry can be used, but although not yet routinely recommended in clinical practice. But it still can be informative, of course, for the clinician. Now, I want to make a plug to the new biomarkers that we talked about, the CVS and Pearl. And the first point I'd like to make is that because of this nature of the CVS, that is really, again, typical of MS plaque, that can actually allow you to differentiate new lesion activity caused by MS versus new lesion activity that can simply be caused by comorbidities that create non-specific lesion due to migraine, for example, small vessel aging. And that can inform the clinician on whether or not they should consider treatment in DMT, a change in DMT treatment or not. And again, if it's an MS plaque, your perspective on the patient will be different than if it's a non-MS plaque. The other aspect is the Pearl. So as I pointed out, Pearl is a marker of this compartmentalized chronic inflammation, a smoldering inflammation. So now we finally have a readout on that biological process of the disease that was pretty much blinded to us before. And that can be actually useful to predict severe disease worsening. And a lot of studies are now showing this longitudinally, that the number of baseline Pearl can predict how the patient will do over time. The other more exciting component to me is it could actually even assess treatment response with a new class of drugs that have been developed right now in clinical trials, are brain penetrant drugs targeting this very specific chronic CNS inflammation, such as the BTKI. And there was a recent breakthrough shown at ACTRIMS earlier this year, where one of these BTKI, the so-called tolebrutinib, was analyzed from this phase 3 trial, was actually analyzed through the prism of the Pearl. So the clinical trial was able to collect susceptible imaging through their phase 3 trials, about 1,000 patients. And what they were able to show in that, first of all, in the placebo group, people that did not receive tolebrutinib, and these are patients that are progressive in nature, they're actually non-relapsing, so secondary progressive MS. The number of Pearl at baseline could predict the worsening of the disease over time. And specifically, the people that have the most Pearls on the baseline MRI had the worst incidence of progression at 6 months. But the really exciting piece is that the group that was treated, though, had the exact opposite trend, where the people that had the most Pearl actually had the greatest reduction in disability progression, really pointing to the fact that this drug will actually target chronic inflammation and could modulate progression of disease over time. So this is a very exciting biomarker that probably will have a clinical use in the very soon future. So in summary, I'm going to wrap it here and pass it over to Dr. Mahjan. Before I do that, I just wanted to summarize one more time the point that I hit on today, which I hope will stick with you, is that the role of MRI is clearly expanding with this new McDonald criteria, the 2024 revisions. And the most important change is the introduction of 2 novel imaging biomarkers, the so-called central vein sign and paramagnetic rim lesions, that are not part of this criteria. And the goal, again, is to move earlier to earlier diagnosis, actually become even a biological diagnosis more than a clinical diagnosis, but while keeping or increasing the specificity that we need to have an accurate diagnosis in patient and treat the right patient at the right time. And then CVS and Pearl can have also very soon a clinical value for monitoring patients over time, and again, potentially helping us to really identify what is MS specific in terms of lesion activity, disease activity, and chronic inflammation, and therefore can help expand the role of MRI for monitoring MS. And with this, I'm going to stop here and pass it over to the next speaker.
So after that, everyone's been warmed up about the 2024 update. So I'm going to talk about how to implement these changes that Pascal just outlined into clinical practice, and how we can use AI to help us in this regard. So I have no disclosures here. And so these are kind of the summary slide of all the McDonald's criteria changes that are being proposed. And as we can see that the DIS and DIT that we have been following based upon the 2017 criteria is now being attacked, and now is being replaced by other more kind of sensitive parameters, especially as you can see in here, the CVS, the central vein sign, and the paramagnetic rim lesion sign that are gaining more and more importance for the diagnosis of MS. And if you look at this last column here, almost every one of these columns require an MRI. So obviously, what I'm saying is that MR is central to the diagnosis, and that we have to move beyond DIS, DIT to other parameters as well for the diagnosis of patients with MS. And why is the central vein important is it can be gleaned from this study of 1,004 brain lesions in which they found central veins in 78% of lesions. And as you can see that 94% of these periventricular lesions will show the central vein sign. And as you go from this periventricular to the cortex, through the deep white matter, juxtacortical, and rest of the gray matter, you can see that the incidence of the central vein sign reduces as you go from the periventricular to more peripheral parts of the brain. And so MS has a very high incidence of a central vein sign. So now once you get tuned to the central vein sign, first we have to determine whether it's present or absent. That is, whether we see a central vein or we do not see a central vein, right? So the lesions which show a central vein are like the MS lesions. Here's the relapsing remitting, and here's the primary progressive type of MS. Well, they were absent in lesions of like small vessel ischemic changes versus migraine. So you do not see a central vein in those lesions. Okay, so besides multiple sclerosis, there are multiple other vein-associated pathologies, and this include things like Susac syndrome, in which you can see a central vein it's not really a central vein, it's a vein which is at the periphery of the lesion and not in the center, in around 54%. And besides this, there is also central veins can be seen in cerebral small vessel ischemic changes and other NMO spectrum disorders, migraine, systemic inflammation, etc. So they can be seen in other pathologies as well. As there was one comment which was made that how do we use it separately? So we're going to talk about that soon. So central vein, how do we assess? Pascal's already mentioned it should be a vein right in the center of the lesion, and it should appear as a thin hypointense line, should be visualized in two perpendicular MR planes and runs partially or entirely through the lesion. And this is most important, is positioned centrally in the lesion, and that is located approximately equidistant from the lesion's edges and passing through the edges at no more than 2 places. There are some lesions which were not included or that do not count towards the central vein assessment, and those are lesions which are less than 3 millimeter. Now that is one of the criteria for calling something a demyelinating lesion in the first place. It has to be 3 millimeter in diameter. And so if a lesion is less than 3, it doesn't count. Confluent lesions do not count, nor do lesions which have multiple distinct veins do not count as well. So you essentially have to see single lesion with central vein within the lesion. Also a lesion which is poorly visible due to motion or other MR-related artifacts. So when you call a positive central vein sign in MS, I think this is the most critical thing, is that there are multiple criteria proposed in the literature, things like 40% threshold, 50% thresholds, 3 central veins or 6 central veins, and they have different sensitivity and specificity. But the criteria which has been accepted in ECTRIMS, from which the 2024 criteria came, is this rule of 6, in which more than equal to 6 lesions should show a central vein sign for us to call it a central vein sign positive MS. And if there are less than 6 lesions, then the number of lesions with the central vein sign should be more than the lesions without the central vein sign. And these criteria were found to be sensitive, to have a sensitivity of around 91%. So just shows us the value of this sign in MS. And here you can see this particular image showing multiple lesions with central vein sign. I'm sure I can count more than 6 here. So how do we assess these for the central vein sign in the first place? And there's one is to look at a white matter lesion on FLAIR and then compare it to the SWI images and see if you can see the central vein sign, the same location on both the images. The other thing you could do is a superimposition in a good PACS system in which you can superimpose the FLAIR and the SWI onto each other and see if you can see lesions. And this is an example of that, in which you can see this faint line within the lesions, which are the central veins within these white matter lesions. The other way is to do more higher resolution imaging, like this 3D T2 star-weighted imaging, the central vein sequence, we call it at Yale, and basically in which we find the lesion and the hypo-intense line of the central vein within the lesion itself. And so this is basically our central vein sequence, in which is a very high resolution, 0.65 millimeter slice thickness, in plane resolution of 0.4 millimeter. And this is essentially a 3D weighted T2 star weighted imaging. And as you can see, this is the FLAIR image, and these three are the SWI, sorry, not the SWI, the T2 star weighted images for this patient. What you can also do is to create something called a FLAIR star, in which you combine a FLAIR and a 3D T2 star to create a FLAIR star image, which is great to look at as well. And you can also, such studies should also help us determine lesions which do not have the central vein sign, so we can distinguish those two. And this is seen on this particular image on the right. Here you can see lesions without a central vein within them. And the lesions on the left show you some lesions with the central vein within it. You can also give contrast, and these central veins get highlighted after administering contrast. This is a 3D T2 star weighted GRE before and after contrast. You can see more prominence of these veins within the center of these lesions. And this is one of Pascal's papers showing similar improved visualization of the lesion, of the central vein within the lesion itself. And you can see central veins at different Tesla strengths of the magnets, much better on 7T as compared to the clinical scanners, which are more lower in strength, the 3T scanners. And even the 1.5T can show it, although not as great. But in this case, Pascal has given some gadolinium as well to show the central vein within these white matter lesions. This is what I think Pascal mentioned, the optimized SW, in which what you could do is you reduce the flip angle of your SWI from around 15 degrees to 5 degrees. And here you can see this image, 2.25 millimeter slice thick, in which once I reduce the flip angle to 5 degrees, now I can see not only the veins, but also the white matter lesions adjacent to the vein here, a small lesion here, and which can hardly be seen on this SWI image. So reducing the flip angle gives me more CSF and more better visualization of these FLAIR images, FLAIR lesions as well. So how do we use this clinically? So our assessment is predominantly based upon determining the number of lesions with central vein sign, which are associated with the white matter lesion that we see. So we're going to go through a few cases. Here's a patient on the left image showing multiple lesions in the periventricular and juxtacortical location. There are a few subcortical lesions as well, but remember that those don't count towards DIS in 2017 McDonald's criteria. And if you so based upon this image, we would have said that this patient had periventricular lesions and juxtacortical lesions, and so this would satisfy the criteria for DIS. Now, this person did not have enhancement, so we would not call it MS at this point. But once we run the this T2 GRE sequence, which shows the more than 6 central vein lesions within it, now we're already calling it a multiple sclerosis diagnosis at this point itself. So that is the big difference that has happened with these changes that are being proposed. So this person subsequently went on to have enhancement of one of the lesions in the right occipital lobe, as you can see. Now, at this point, so now which she meets the criteria for DIT, and but this is almost a year later than what would have happened if we had used the earlier criteria. This patient was also found to have a new lesion on a AI report, which was done along with this study. And as you can see, a little lesion was picked up on this in this image. Of interest, the clinical report at this point, even in spite of this AI report, did not believe this lesion and said that there was no lesion and there were no new lesions identified on this scan in spite of the AI report. So how do we use AI in our evaluations? So this is IcoMS report, since this is icometrix's talk. So what we can do is that we can use their FLAIR, our FLAIR sequences, and they can provide us an icoMS report in which they can create volumes of lesions in the periventricular, juxtacortical, and other locations for us. And this is what they can do in the future is using the T2 star weighted images. They can provide us this ICO plus reports in which they can calculate the volume of the central vein sign and the paramagnetic rim lesions numbers and their volume. And this particular patient had the software found 22 lesions with central vein sign. But remember that this report would only be needed to be done at a baseline evaluation. We don't need to follow them. And these are the images of the T2 star as run by the ICO plus report, highlighting the lesions with the central vein sign. Of note, some lesions are not being picked up, which is, I think is a good thing. That means it can differentiate between the lesions with the central vein and those without. We can also use this for longitudinal follow-up, as in this particular patient with, this is the same patient that we've been talking about. And as you can see, this 3D FLAIR initially in 2023 showed this volume, which showed newer lesions as time has progressed over the time course of this patient. And this is another example where AI has been useful, is like this patient's, I'm sorry, this is moving too fast. All right. So in this particular patient, the baseline imaging did not show a lesion, but a follow-up scan in 2024 showed this new lesion, which was picked up by AI tool as well. And another lesion between 24 and 25 another lesion was picked up. So it is performing reasonably well, especially to pick up new lesions, which we then go around confirming whether they are real or not. This ICO report also mentioned an enlarging lesion, as you can see, between this prior lesion and the new scan. And this was obviously an enlarging lesion as well, which was identified. We can also use AI to assess the brain volume change, although as Pascal said, this is optional. We're not sure whether this will be of benefit going forward, but this is just a tool which can be used for that reason as well. Finally, coming to the paramagnetic rim lesion. So this is what we were talking about. And this denotes essentially paramagnetic rim and may denote smoldering disease or also called chronically active MS lesions. And they are best detected at 3T or higher. And it can be seen on SWI or the 3D GRE images. The filtered phase image of SWI is especially useful to identify these lesions. And even the presence of one PRL lesion equals the 6 central vein lesions to make a diagnosis of multiple sclerosis. And a few more pointers. This is a comparison of a patient with Sjogren's on the left and MS on the right. Is that the paramagnetic rim has to be a continuous rim, more than 2/3 of the outer edge. I think Pascal mentioned that. And it should be visible across 2 consecutive MR slices. So there is no paramagnetic rim on these lesions, but you can see a rim on these ones. And as I said, the filtered phase shows it better as compared to the magnitude image. And this was another lesion which I thought was a paramagnetic, but then it did not fulfill the criteria of the more than 2/3 rim. And so it's not really, this would not be called a positive PRL lesion. And just to summarize, just to show a final slide about the ICO-MS Plus report, which shows the volume of the paramagnetic rim lesions and the central vein signs on the same report from T2 star weighted GRE images. So to conclude, I think central vein sign and paramagnetic rim lesions have acquired great importance in the diagnosis of multiple sclerosis, and we as radiologists need to become aware of their appearance and their utilization in clinical practice. And I think AI can be a useful tool to us in identifying and monitoring these patients. I'll hand off the mic to Dirk for his comments.
Yeah, wonderful, Dr. Mahajan, and thank you for sharing some very interesting cases of how you do this in clinical practice, which in the end is by far the most important that we get to work together to improve the clinical practice. So from my side, I would like to end shortly with giving a little bit of an overview of indeed the AI tools and how they can be implemented in clinical practice. And I also want to share some future perspective of how we look at that. So from that perspective, I first want to show you how these tools can be integrated. I think Pascal and Amit showed very impressively that the FLAIR and the T2 star SWI scans are now more and more becoming important for these paramagnetic rim lesions and the central vein sign lesions. They can be simply sent to these AI models. They do the calculations. We do that with convolutional neural networks, and more specifically longitudinal convolutional neural networks, to generate also these kind of reports that then come back into the PAC system. So this is all happening as a background service, so that there is no interaction with the software going on. There is also something that is called the pre-populating reporting template that I will also touch upon in a second. I want to first show you the icobrain MS report. Amit already showed it also, that it is able to support with the assessment of lesion dissemination in space. The AI tool here is currently identifying lesions in 3 out of the 5 topographies on the brain scan. Of course, for spinal cord, there is a specific spinal cord scan that I will come to later. And for the optic nerve, it's something that is some work in progress. We're also looking at the lesion dissemination in time, for example, through new and enlarging T2 FLAIR lesions, as well as the GAT-enhancing lesions, which are also very important when monitoring patients, because these are identifiers of MRI lesion activity and therefore a potential sign that the patient should switch treatment. It was also touched upon by Pascal and Amit that brain volume changes, are also called brain atrophy, is currently optional. So this is also something that the AI is adding and can be commented on. And this is a way to also measure end organ damage, because of course multiple sclerosis is a neurodegenerative disease as well, and the end organ damage is important in terms of future progression. For both the lesions and the brain volumes, there is also a data comparison with a database, not only a healthy population, but also in multiple sclerosis population, to help better give context to those measurements. For example, for the MS lesions, it's interesting to know how many there are in a similar patient with a similar disease duration, and that is done through this comparison with that population database. Same with the healthy population database. This gives a bit of an idea on what is the brain reserve of that patient, which potentially might mask some activity that is still subclinical but might become clinical soon. So let's have a look what these reports can add when looking at a case. And to do so, I want to show a case that has been read without the AI. So here you can see a FLAIR scan on the left, and there is the comment from the radiological report that there is many T2 hyperintense lesions. Of course, it's quite intense to count them all, and they're in the different topographies of multiple sclerosis, and also a moderate global atrophy has been described in that report. So this then go to a more data-driven approach, and here I have a very exciting case of a patient that has been followed up over 20 years with these kind of tools that really gives that overview of the different markers over time. So you can see the two charts where the flare lesions are followed over time. You can see that there was an increase with also some bumps of relapses and then some stabilization over time. And we also measured the whole brain atrophy, the whole brain volume. You can see also that that is decreased, but this is more or less following a pattern of normal atrophy that we also expect in a normal population. However, the patient has a relatively low brain volume, so we can hypothesize that the brain reserve of that patient is limited, meaning that if there is exacerbations in terms of flare lesions, that has a more likely consequence towards symptoms. So let's have a look at that also there for this particular patient. This patient was diagnosed at an age of 23 and had an EDSS score of 2 in the first years. This was at the time that she was not followed up with AI yet. She had some self-reported tiredness and some signs of cognitive decline, and some testing showed a slight increase of EDSS score. But then there was a significant breakthrough of the disease with an EDSS of 6 and some brain fog. Unfortunately, the patient needed to stop working, and also icobrain was started. And what is interesting now is that also some years later, at the age of 33, there was a treatment switch towards a high efficacy treatment, and that stabilizes the EDSS at 4, which she has been on for the next 2 decades. So this is a nice example from the clinical perspective how radiology plays a crucial role in detecting the subclinical disease activity before the actual breakthrough of disease, and therefore avoid a further worsening of the disease. Of course, from the radiological reporting perspective, it is a lot of work to report on all of these measures that are important from the clinical decision making. And for that reason, also the AI tools like icobrain give pre-populated radiological reporting templates. That helps with the standardization of reporting because it has that standardized language, but also it includes the state-of-the-art structure of the report. So the new guidelines, Pascal mentioned them as the 2021 CMSC NAMES Magnum guidelines, as well as the new McDonald criteria. These are also included in those pre-populated reporting templates, meaning that when you use them, you will also be report on the measures that are expected from those guidelines. It also reduces the reading time, and also an important factor, it allows for the reimbursement, because nowadays these AI tools are reimbursed for, and when the right language is there in the report, it also allows for optimal billing. Of course, a major topic of today's webinar was about these paramagnetic rim lesions and the central vein sign lesions. And as Amit mentioned before, also there are some AI tools available. This is what we call our icobrain MS Plus report that does the quantification of the paramagnetic rims as well as the central vein sign lesions. Amit showed some nice cases of patients with a high number of central vein sign lesions, which is very typical in multiple sclerosis. Also, there is the option to look at substructures as well as the spinal cord. Also, 2 markers where, from the research perspective, there are interesting relationships with future progression and therefore potentially also worthwhile investigating and following up upon. Then the last innovation I would like to share with you is the spinal cord assessment. So it was clear also from the talks of Pascal and Amit that the spinal cord is also one of the 5 topographies, and lesions in the spinal cord should be considered as a part of the dissemination in space. And also here, the AI tool, icospine-MS, can help with the assessment of spinal cord lesions as well as spinal cord atrophy, which is also related to those symptoms. So that wraps up the part on how AI can be used in clinical practice, and where there is also some future perspective with the new measures like the paramagnetic rim lesions, the central vein sign lesions, and spinal cord assessments. So I would like to conclude the different topics of today. We showed in this webinar that the role of radiology is enhancing not only for the diagnosis, where we show that in the 2024 McDonald criteria, but also in the monitoring of multiple sclerosis. The paramagnetic rim lesions and the central vein sign lesions are now important concepts that should be included in the clinical practice and therefore also in our radiological reports. I also showed that AI tools can definitely also help with improving accuracy and increasing consistency and improving the billing. So with that, I would like to hand back the word to Dr. Gibbs for further questions.
That was fantastic. Wow, there was so much good information there. We went right up to the hour, which was good because you guys couldn't have done it any faster. I know there was more that you didn't even get to say. And Dr. Sethi was kind enough to answer some of our questions. I asked him to answer some because I knew we wouldn't have time to get to them at the end here. But it looks like we have a couple more. Dr. Solomon's questions are always too hard. I can't even barely say it, let alone answer it. But we'll see if we get to that. But let's ask the other one real quick that we have left here. What about optic nerve assessment? I'm assuming because that just popped up that is for the icometrix evaluation, I think. And I think you mentioned, Dirk, that that's something that's coming. Did you say that?
Yeah, this is something that we're investigating. It's of course something challenging to detect because the appearance on the MRI for the different topographies is more clear as clear white matter hyperintensities. For the optic nerve, there is also some appearances that might be mimics of optic nerves. I think Pascal might be better placed to comment on what's the best way to detect the optic nerve lesions on MRI.
Yeah, I mean, I alluded to that in my slide. The recommended protocol will be coronal, T2 fat suppressed, austere sequence, and T1 post-GAD. You can also look on the FLAIR 3D FLAIR sequence. It's just a little less reliable, I would say. You can have some false positives, so you have to be careful there. There's also more advanced sequences and emerging technique like 3D DIR that have been interesting to look at, but this is adding more scan time and then becomes a trade-off of what can you do in your routine imaging versus how useful you think this is going to be. So if there's a true suspicion of optic neuritis clinically and then you want to confirm that by imaging, it might be worth to do that. If you don't have the time or don't suspect that, you can always rely on the other biomarkers. And that's the beauty of the McDonald criteria is they basically provide more options to establish MS and don't solely rely on one. You can actually have different biomarkers you can use aside from the optic nerve lesions.
And I think that ties in with Dr. Solomon's second question there about the optic nerve imaging. Should it be included? And you guys,
yeah, I think it's exactly what Dr. Solomon said. Yeah, exactly. So it could or could not. I would recommend based on the local practice, and maybe actually Amit might have some input on that based on his own practice at Yale. Would you think we'll have the time to add more sequences to MS Brain right now or not?
No, obviously, at this time, it takes long, and so it will add on time. So, but I think more important than that is, radiologists who read scans, they can tell you that, evaluation of the optic nerves is not easy. And often people may call pathology when they maybe not. So I have a feeling that it may introduce a lot of kind of false positive evaluations, especially for the optic nerve. So we need to have a good solid imaging plan before we say that we should do everyone's optic nerves, because I don't think the MR can be the only tool to assess for optic involvement. I don't know other radiologists what you guys think about, but that's what I feel.
That makes sense. How about, should we switch since I'm sorry to have to switch topics so quickly, but let's get that last question. How sensitive are PRLs to smoldering activity and silent progression, which I think I've seen some stats in this talk, or in one of the talks. I know, Dirk, you alluded to this at the very beginning, I think. And of course, Dr. Sethi did as well.
Sorry. Yeah, I indeed, I think that paramagnetic rim lesions are probably the one of the most important markers for chronic active inflammation. There is another one that are called the slowly evolving or slowly expanding lesions. That's another way of yeah, as a marker for chronic active inflammation or the compartmentalized inflammation, as Pascal rightly said. From that perspective, these slowly expanding lesions are much more difficult to assess in a clinical practice because it requires the assessment of the lesions over time, but also to see whether they are concentrically growing, as well as they should also not grow too fast. So that makes that the imaging needs to be highly harmonized. And from that perspective, I think the paramagnetic lesions are probably the lesions that are most feasible to add into clinical practice setting, and I think are a very important marker for smoldering activity.
Yeah, and if I may add, oh, I'm sorry, Amit, you want to say something first, maybe?
No, sorry.
Okay, if I may add to this, there are also two concepts. Right? The question from Ahmed is the smoldering activity and silent progression, which is, to me, in my mind, are slightly different things. Smoldering activity is really the smoldering inflammation, right? What I'm thinking here. And so Pearl is really a biomarker of that compartmentalized chronic inflammation, which sometimes is called smoldering inflammation, and which is really a focal process, I think, here. The silent progression is interesting because this is, and has been published by other groups, including UCSF, where they look at spinal cord, for example, the atrophy in especially the C2, C3 level as a predictor of this silent progression that is subclinical and that appears at some point in the measures. And so it's a broader concept. It's not just the Pearl and chronic inflammation, it's also neurodegeneration occurring across the CNS and not just the brain, but also the spinal cord. Because again, the cord is tightly correlated to disability. We should not forget that. And that's why the tools from icometrix on the spine, to me, sounds very attractive, because if we can measure this clinically, we really provide clinician another tool in the toolbox to really accurately assess this progression that sometimes is masked and not seen, detected clinically, right? So I don't want Ahmed to think there is only one Pearl. There are many ways to look at this progression of disease and many tools, and Pearl is one of them. There are definitely other metrics, and spinal cord is definitely one of them.
So is that available right now, Dirk? Because sorry if you already said that, but I've been asking for that forever. I've wanted the cord for MS, and I know it's very, very difficult. So is that something that's available?
Yeah, it's available for research purposes at this moment, and we're going through the FDA pathway there. In some parts of the world, it is already available, but in the United States, it's currently for research purposes.
I agree. That'll be so very, very useful. I think we're gonna have to stop there, y'all. So if you have more questions, I think all of the speakers provided their email addresses, but if you want everybody to be able to benefit from your questions and their answers, maybe also we can put them on social media somewhere, because I know all these guys are on there too. Any last words from anybody before we wrap up? Anybody?
No.
Thanks so much, Dirk, and for icometrix to sponsor this. This was so much great educational content. I can't wait to watch it again. For everybody watching, if you want to see it again, if you joined late, or if you want your colleagues to see it, or you take more notes like I will, this will be available on the ASNR website, and anybody can watch it. Again, you just have to have an ASNR login. I think Colleen said it'll be about a couple days or a week, and it'll be on there. So for posterity. So thank you again to all of our speakers for that wonderful educational experience. Thank you to icometrix for sponsoring this and looking out for all of us. And until next time, thanks all.
Thank you.
Thank you.